The APC CPC exam is difficult, but definitely not impossible, and you can increase your chances a lot by knowing which type of questions trip people up the most during the exam. Today, I'm going to be covering the concepts that people tend to miss the most and lose the most points on the CPC exam so that you don't wind up making those exact same mistakes. But of course, your chances are going to be a lot better if you get the right training from the get-go, like today's sponsor, Preppy. You can find out more about Preppy with the link in my description for medicalcodingmasterclass.com. Now, with the CPC exam, it is 100 multiple choice questions, and they are randomized from a bank of over 1,000 questions, and they change. They move questions in and out. So there are certain concepts, though, that they like to test people on. And we're going to cover a lot of those today. Now, this is not just me making things up because I think people trip up on these questions a lot. This is not me hearing things. These concepts are actually the concepts that were covered during Teach the Teacher at HealthCon, which I recently attended. And the AAPC said, yes, these particular concepts are the ones that people lose the most points on for the exam. So I have made some questions that test on the exact same concepts so that we can go over these together and that you can benefit from not making these same mistakes. And again, there is no this question is the one that trips people up, because you will not find anywhere online the exact questions that are on the exam. It is a huge bank. And again, it's very active as far as questions coming in and coming out. If questions aren't performing well, they do pull them. If they think that someone may have compromised a question, it gets pulled, and they will develop questions that are of a similar concept, but not necessarily the exact same question. But this one in particular tends to trip people up, and that is the closure. So let's look at a sample question where we are coding for a lesion and a closure. So this one is a patient has a 1.5 centimeter basal cell carcinoma removed from their cheek, and the doctor also takes 2 millimeter margins. The closure is a simple one-layer suture of 2.5 centimeters. What CPT codes should be reported? Now, there's a couple of key things we need to look at while we are reviewing this type of question. First and foremost is that this is a basal cell carcinoma. So oftentimes in coding, we differentiate lesions between, are they benign, which is non-cancerous, or are they cancerous? And a basal cell carcinoma is a cancerous type of lesion that was removed. The reason why we have different codes for these is because if a lesion is cancerous, that is a higher risk. We want to make sure that maybe we're taking wider margins. We have to monitor it more. So there's a slightly different price than there would be if we were taking out something that's just benign, correct? So we're looking at the type of lesion. We're also looking at the size, not just the size, but the margins as well. So 1.5 centimeters and then 2 millimeter margins means margins are each on that side. So we take the widest area of the lesion and the narrowest margins, we add those together. So if we take 1.5, even if we add the 2 millimeter on each side, so 1.5 plus 2 millimeter on one side, 2 millimeter on the second side. And let me bring up my book so I can show you kind of what we're talking about here. So here in the CPT book, we're talking about the measuring of lesions, and these are the samples that they give us, where we're talking about the excised diameter, the largest area there, plus the narrowest margin. So in this case, there's some samples here, and I'm not going to get too far into how to measure the lesions themselves or these samples here, but you can see there are different samples here as far as like different sizing of lesions, how we measure for lesions that are wider on one end than the other, ones that are a little bit asymmetrical. So they do have examples here. I have whole videos on lesions. I do whole presentations because I'm the skin girl. But the one concept that you do need to understand is what closures are and are not included with lesions, which they do discuss over here, not just in the benign, but in the malignant ones as well. They have the same instructions. And what these instructions essentially say is that the closure is included if it's a simple one-layer closure. The only time we code additionally is if we're doing an intermediate or complex closure to that lesion. So 2 layers or more, or maybe 2 layers with undermining, or a more complex closure. And you can see that in the guidelines. I believe it is, excision including simple closure of malignant skin lesions includes local anesthesia. Excision is full thickness and includes simple non-layered closure when performed. So that simple one layer is performed. And that's what this question is really kind of testing us on. So when we look at this, we've got a couple of options. We've got this one, this 11442 is a benign code. This one is the 11642, which is the malignant codes, and then the closure, and then the malignant code itself, and then the benign code with the closure. With the CPC exam, the answers themselves are randomized. You can see they're no longer really an A, B, C, and D. They're just going to give you these radio buttons, and you have to select which one. And they're going to be scrambled up. So someone might get this question in the test bank, and they will have the answers in different order. So you can't really memorize this question is answer C. That's why I really discourage people from saying, oh, let's buy the CPC exam, real questions that people are selling online, because you can't really memorize what the answers are for these. It really and truly is the concepts. You need to understand the concepts of medical coding and these types of questions. If we again go back to our book, we have the benign codes, we have the malignant codes, and then we have the closure. We know it's not going to be these ones with the closures because the closure is included. So is it going to be the benign code or the malignant code, the 11642, which I'll just bring up real quick and show you. With lesions, we have to pay attention to the size, the location, and the closure as well, and if it's cancerous or non-cancerous. So these are our cancerous. 11642 is excision, malignant lesion, including margins, face, ears, eyelids, nose, lips. And then this is for excised diameter of 1.1 to 2 centimeters, 1.5 plus the 2 plus 2, because remember it's on each side, is 1.9. So that's 2 and under. So it's a 11642 would be the correct code here. And that's what it's testing us on. It's testing us on that concept of the lesion and the closure. You might not necessarily get one where it's testing you on the simple is included. They might be testing you on the patient has a lesion removed and it was an intermediate repair. And do you know that those intermediate repairs do get coded separately? So again, it's this concept that they're testing you on. I'd also like to quickly remind everyone that I know some people say, oh, Victoria, I think you're talking too fast. I just remind you, you can pause the video. You can change the speed of the video on the YouTube settings. I personally absorb things a lot faster, and I want things to go a lot faster paced than some of the videos that I watch. So I watch videos at a much faster pace, and I also speak at a slightly faster pace than some people's, I'll say, abilities or preference. So if you want to listen to this a little bit slower, you want me to slow down, you can just change the settings on YouTube. The next concept that people struggle with on the CPC exam is fracture care coding and the like cast placements and what all is bundled in there. So in this particular question we have here, a patient is seen in the hospital's outpatient surgical area for treatment of a closed displaced midshaft fracture of the left humerus. After clinical evaluation and imaging, physician performs a closed reduction with manipulation under sedation. Pay close attention to what type of manipulation is being done, because there's difference between open and closed fracture and open and closed treatment of a fracture. So in this case, we are doing a closed reduction. So that's the closed reduction. That's the procedure being performed with manipulation under sedation. No incision is made. The fracture is realigned manually, confirmed with fluoroscopy, and a long arm cast is applied. So we have to pay attention. Is that cast included or not? So we have a couple options here. Some of them look like they have multiple things here. This 29065 might be, I'm thinking this cast. So we need to know if the cast application is correct or not. We all have these LT modifiers on here because it says it was done on the left side. So we can't eliminate anything just based off the modifiers, because it looks like they all have the right modifiers on them. So let's take a look here. We have this 24500 and then 250. So let's take a look at our book. I'm actually going to split screen this so it looks a little bit more like it does when you're taking the CPC exam if you're using your ebooks. So I can also bring up here some of the search functions. So this is the search function that you will have when you're taking your exam. It's not going to be like an encoder search function. You're not going to have access to Codify. But let's say I want to just go ahead and say, I'm going to look up this code and see what it says. So 24500. To search through these, you have to also understand the tactics of how to search and what to click on, because there's a lot of options here, right? But pay attention to these headers. This is the surgery section. This is our musculoskeletal system section. And this is the index. Oftentimes, if you want to go to the code itself, the selection that you're going to want is the one that just shows the CPT code here. You can, if you're like super confused and you're like, I don't know, like what to click on or whatever, oftentimes this very last one in the index will take you to something that you can click directly to the code on. But if you want to just go directly there, look for the one that just has that code and it is in the right section. This is the musculoskeletal system section. And you can click on the 172. That will take you to the code. But just to kind of demonstrate for you the other way, if you go here to the index, oftentimes they'll also have links now. So if you want to go here, 24500, you can click the link there as well. It's obviously going to save you some time if you go right to the one there, but you have to search for it in the results. And depending on what code you're looking for, there might be a huge string of search results. We have the 24500 and 24505. One is closed treatment of a humeral shaft fracture. This one is without manipulation, and this one is with manipulation, with or without skeletal traction. So what did we do in this one? It says with manipulation. So it's going to be one of the 24505 questions, right? But what about this 29065? Well, let's take a look at some of our guidelines as far as, is this 29065 code going to be included? All services that appear in the musculoskeletal system section include the application and removal of the first cast, splint, or traction device when performed. So that tells us that we are not going to be coding this separately. So in that case, the answer for this one is going to be our 24505 with the LT modifier. The casting is not billed separately because according to the guidelines, it is included, and that means we don't bill it out separate. Now, this next question is a 68-year-old Medicare patient presents for a routine pelvic and clinical breast exam as part of her cervical cancer screening. She's asymptomatic and has regular screenings in the past. Her physician performs the service as part of a Medicare-covered preventative visit documenting a normal pelvic exam, visual inspection, and clinical breast exam. No abnormal findings or problems were identified. What HCPCS or CPT code is reported for this encounter? So anytime you see that the AAPC puts on here Medicare patient, that should be setting off your spidey sense, because oftentimes when they specify that it's a Medicare patient, it means that they're looking for you to know that there might be something that impacts the code selection because this is a Medicare patient. We have a series of codes here. We have the 99397, SO612, Q0091, and GO101. These codes aren't close in the range, so we can't just like look at the same page and go, oh yeah, it's this one on the page. We might need to know a little bit about the Medicare patients. I'm not going to look up every single one of these codes for you, but I will tell you this code 99397 is just a routine preventative exam for this particular patient's age. This S code is used for Highmark and some of the Blues plans for GYNs. The Q code here and the G code, though, a lot of G codes are Medicare codes. But we also have this Q code here, Q0091. So let's take a look at what we've got here. I'm actually going to pop into the HCPCS coding book, which I think would be a good place to start because 3 of the 4 options are HCPCS codes, and we could probably easier search these out than some of than starting in our CPT book. We know a lot of Medicare codes are G codes. So what's GO101? And it actually is telling us here, screening examination of disease management. This is a GO101, cervical or vaginal cancer screening, pelvic and clinical breast exam. Well, that seems pretty spot on. What's this Q0091? So that's just the pap smear itself. And this patient had a routine pelvic and breast exam, not just a pap smear. Let's take a look at this SO612 as well. Annual gynecological examination established patient, but it doesn't, service not separately priced under Part B. But if you know about Medicare, Medicare likes those G codes, and this G code does specify that it is the pelvic and breast exam and is for a Medicare patient. You should make a note somewhere, probably in your book, that if you see a G code, that's probably a Medicare patient. S codes are more for some of the Blues programs. But in any case, GO101 would be the answer for this one. So the concept that they want you to understand is that there may be separate codes for Medicare patients. Things like different injections, things like colon cancer screenings, things like the Medicare annual GYN exam. So pay attention when you see that they are outlining for you that this is a Medicare patient. Now, next, I am not a big cardiology girly, but the concept that tends to trip people up the most in the cardiology section is selective catheterizations. And I even had some trouble making a mock question for this, but this is the one we have. The provider performs a femoral artery puncture and advances the catheter selectively into the left renal cortical artery branch. What CPT code is reported? So we have a couple of options here. The first two options here are pretty close together, and they're just one code versus some others, which are a series of codes, a couple of different codes here. When we look at the guidelines for selective catheterization, what we really need to understand is that for selective catheterization, we only report the highest order vessel catheterized. The lower order vessels are bundled. So in this case, we might want to take a look at our vascular families in our Appendix L. Now, the thing I don't like about this section where the vascular family illustration is you can't search the text there. So you have to kind of like zoom in and look and find where the cortical artery branch is. And I think I saw it down here somewhere. Okay, you might not be able to see this because it's very tiny, but here in the third order, we have the renal cortical, which means this is a third order vessel that we're doing here. So we know it's going to be either the first or second option because these are the ones that have all the additional things that are bundled in, unbundled, basically. So it's going to be either 36247 or 46. And if we look at these, we have selective catheter placement, arterial system, initial second order abdominal, pelvic, or lower extremity artery branch within a vascular family. This one is third order. And when we looked this up, it said third order on the Appendix L illustrations. So in that case, it's going to be our 36247. Next, we have here a question about twin deliveries. So this is another concept that people struggle with, is specifically with maternity care with the twin deliveries. And what we need to understand here is the maternal package. So we have our prenatal care, our delivery, and then our postpartum care. That's usually the whole bundle if the provider or provider group does the whole thing. Sometimes they might not. Sometimes the patient has prenatal care with one provider group and they wind up delivering at the hospital with a provider who's not part of that group or somewhere else that wasn't part of that. Sometimes the patient maybe doesn't get prenatal care and they just have delivery and postnatal care. So we need to understand a little bit about that OB package. With twins, it's a little bit different because we can bill for two deliveries, but the prenatal care and postnatal care really doesn't change. So how do we handle that when we have two babies being delivered? We can't double dip on the pre and postnatal care, but we do get extra credit for that extra delivery work. So in this question, it's saying a pregnant patient delivers twins vaginally after a previous cesarean section. That's referred to as a VBAC, a vaginal birth after cesarean. The provider that delivered both babies is within the group practice that provided the prenatal care and will also provide the postnatal care. What CPT code is reported? So let's take a look back at our book. So we're looking at these 59. This is an amniocentesis. That's way off, but 59610. Routine obstetric care, including antepartum care, vaginal delivery, and postpartum care. And this is after a previous cesarean section. So we're kind of in the right spot here. But are we billing this times two? No, because remember, we can't double dip the prenatal and postpartum care. The 1-2 is vaginal delivery only. So would we bill for the whole package and then one vaginal delivery only, which is, it looks like our option 59610, 59612. So that whole package and then the extra delivery, that looks right. 612 twice, then we're not capturing that prenatal and postnatal care. This one's the whole OB package twice, and this one had some kind of weird other thing on it. 59610, that's going to capture that whole OB global package. And then 59612 is then that extra delivery, that twin with the 51 modifier. So that's going to be our correct option for that one, our 59610, 59612 with the 51 modifier. Next we have, and this is another one that was not my favorite, chemodenervation. Patient presented for Botox injections into the muscles due to continued muscle spasms. The physician performed the chemodenervation injections. 2 injections were performed on the right and left arm, so 2 on right, 2 on left, and 6 injections each were performed on the right and left legs, so 12 total on the legs, and then 4 total on the arms. This is a lot of CPT codes to look up. Look at this is, I can see why people would get overwhelmed by a question like this, because they're like, oh my God, if this is a question that overwhelms you, feel free to flag this question and come back to it. And you can do that by, if you hit the button here on the contents. Now, this is just a mock exam, so I'm not in an active exam portal or anything like that. This is just basically a background on a PowerPoint that looks like the exam, so we can kind of get a feel for the formatting. But if you hit this contents, then that will show you all the exams that you are, exam questions that you have flagged. So if you want to flag this and then come back to it easily right away, hit that contents and it'll bring up all the questions here on the right-hand side and it will show you which ones are flagged. But you're not going to escape it today because we need to practice these questions. So let's bring up our book. 64642, chemodenervation of one extremity, 1 to 4 muscles. And then we have this code is each additional extremity. And then we have down here these chemodenervation of one extremity, 5 or more muscles. Now, here's the thing I want to point out to you. This is not 1 to 4 extremities. This is not 1 to 4 injections. This is the amount of muscles that are injected into. So we are chemodenervation of one extremity, 1 to 4 muscles, 1 extremity, 1 to 4 muscles. And this is 1 extremity with 5 or more muscles. Okay. This is each additional extremity, not each additional muscle. And we're not going to use modifier 50 on these because I think there's an instruction on here somewhere that tells us not to do that. Yeah, right here. Do not report modifier 50 in addition with these codes. Okay. So there's a lot to break down here. So we have the 2 injections for the right and left arm, 6 injections for the right and left legs. So 64642 is 1 to 4 muscles, 64642 for one extremity, 64642 for the second extremity of the arms, because each one had between 1 and 4. So there was 1 to 4 here, there was 1 to 4 here. 1 for 64642 for one arm, and then each additional extremity. And that's for those. But the other ones, did they have 1 to 4 muscles in the legs? No, we had more than that in the legs. We had 5 or more. So we're going to have that one extremity. So one of the legs was 5 or more, 64644. And then the second extremity, meaning the other leg. So that means it's going to be our second option here. And I'll kind of just mark this up a little bit to further demonstrate what's going on here. So we have, let's say, the right arm, right leg, left leg, because they're each extremity and it's the number of muscles that are being injected in each extremity. The next question we have, 55-year-old woman with no current symptoms presents to her primary care provider for a routine annual wellness exam. She has no history of breast cancer, no complaints. As part of her preventative care, the provider refers her for a screening mammogram. She goes to an imaging center where a bilateral screening mammogram with CAD, computer aided detection, is performed, what CPT code is reported. Now, notice none of these have a 50 modifier in these, so I'm guessing that these are all bilateral codes. Let's take a look though. So just for the purposes of the exam, again, we're talking exam strategy here. If you want to learn about how to look things up on a code, I have separate case videos on how to do that. But this video, we're talking about exam strategy and how to manage through the exam. We're going to go right to this section where these codes are. We're going to open up our book. So we've got a couple of different codes that we're contemplating the selection on. 65, 67, 66, 61. 61 is diagnostic digital breast tomosynthesis. And that doesn't sound like what we're doing. Unilateral. Bilateral screening mammography. 66 is diagnostic bilateral. And then 67 is, keyword here, screening mammography bilateral. So you have to pay attention not only to, is it unilateral or bilateral, but is this screening or diagnostic? This is a patient that is just getting a screening mammography done. So in that case, screening mammography bilateral, including the CAD1 performed, that's going to be our code selection 77067. Now, this question we have, it says 45-year-old male patient is being evaluated for possible acromegaly. His endocrinologist orders a hormone growth suppression test. So this is a lab testing kind of question. The lab performs full protocol, which includes multiple timed blood draws for glucose and human growth hormone levels after an oral glucose load. What CPT codes are reported for this suppression testing? We're kind of looking at what is included as part of this test and what's not going to be coded out separately. So is this going to be an 80430, or are we going to add on some additional things here? Are we going to bill this multiple times? Let's take a look at what we're looking at here in the book. So is 80430 going to represent this whole panel, or are we billing out separately, like for this 82974 or 82947. When we look at this code here, 80430, growth hormone suppression panel, glucose administration, and the panel must include the following: glucose and human growth hormone. Glucose, quantitative blood, but that's included. That's included in the panel that we're looking at. So we're not going to code it out separately. And we're not going to bill just for this first selection here, which is all the different separations of the tests. So in this case, the whole entirety of what's being performed is encompassed in that panel. There's nothing that we're going to bill additionally, or nothing that we're going to separately report. Everything is globally reported with the 80430. Now, this next question is on vaccines, and vaccines can be very confusing for a few different reasons. There are codes that are age-based and have counseling involved. And I think we've gotten better over the past few years of acknowledging that in order to bill for a code that says counseling was performed, that we have to have some documentation of the counseling being performed. It used to just be people thought that there were ones that were age-based, and then there were ones that are pediatric and adult, and that's not true. There's ones that are pediatric with counseling, and then there's ones that are not age-based at all. The peds ones are per vaccine component, and the others are per injection. So if we look at this 90460 code, immunization administration through 18 years of age, that includes age 18, via any route of administration with counseling by physician or other qualified healthcare professional, first or only component of each vaccine or toxoid administered. So each component of each vaccine. Having said that, if we look at a question here where a pediatric patient presents for routine immunizations, provider administers the following vaccines during the visit: DTaP, IPV Hep B, which is Pediarix, and then the pneumococcal vaccine. Provider also performs the face-to-face counseling with the patient regarding vaccines. And I guess in this case, it would probably be the patient's parents. These are the codes, I believe, within vaccines, we have codes for the medication, the vaccine itself, and then for the administration of it. So one for the juice, one for the stab. The CPT codes reported, it's looking like they're all going to be some variation of the 90460 or 90461, but how many? So when we look at the question here, the DTaP is actually 5 components: diphtheria, tetanus, pertussis, the IPB, and the Hep B. So remember, we have first component of each and then the additional components. And then we have first component of the pneuma. So we're going to actually build this 90460 once for that first vaccine, for the first component of the first vaccine, again, first component of that second vaccine, that pneumo. Now it looks like all of these have the same code for the medication itself, so we don't have to really pay attention to this or this because they're really testing us on that vaccine administration. Any route, and it was a pediatric patient. They do document that they did the counseling, and this one here is going to be our third option here, the 90460, first component of each vaccine. So one for the DTaP, one for the pneumo, and then all those additional components that we're billing here. So this is our first component. We already got that with the 90460. And then 1, 2, 3, 4 additional components. So like an MMR vaccine, measles, mumps, rubella, has 3 components: measles, mumps, rubella. And that's the concept that we need to understand for the CPC exam. What is the correct code for the ones where we are billing pediatric patients with the counseling? Remember, it has to state that that counseling was done. Otherwise, we're going to use our other codes, our 90470 codes, and I'll show you what those look like. So these codes, the 90471, these aren't necessarily adult codes, but people think of them as the adult codes because it says immunization administration includes percutaneous, intradermal, subcutaneous, or intravascular injections, one vaccine. So these are per vaccine, not per component. And then it doesn't say if there was in regards to counseling. Technically speaking, if you have a pediatric patient that got a vaccine and there was no counseling performed, these aren't like adult codes. They're just not age restricted codes. So if there was no counseling performed, you could bill a 90470. I have a whole other video on vaccine administrations if you want to go check out more about vaccine administrations. But for the purposes of this one, we're kind of looking at the component concept. And that's what tends to mess people up on the exam. E&M coding, of course. This particular concept, though, is time-based coding. And one of the cool things about this, though, is remember that we're going to have access to that E&M calculator during the exam. So this question here, we have a 52-year-old patient. They present to their neurologist for follow-up after a recent hospital discharge. During the visit, the provider documents a moderate level complexity and spends 15 minutes reviewing her recent tests. Neurologist then spends an additional 40 minutes providing counseling, coordination of care regarding her new diagnosis and treatment plan. For multiple sclerosis, total time documented for the visit is 55 minutes. So what CPT codes are reported? So we need to know how we report for prolonged care, but the E&M calculator is going to save us on this one. So let's put in just a random data service here. And then we're going to go here to our time-based coding. And when we go into time-based coding, okay, what's our type of service? This was an office visit. They were going into the office to talk to their neurologist. And it was an established patient because they're returning for follow-up. But was this a nurse visit? No. And when we go to our time-based coding, does the documentation reveal total time? Yes. And then enter the total time in minutes. It's going to make easy work for this for us. And it's going to tell us 99215 and 99417. Remember, we can only add the prolonged codes on for office visits for 99215. So that could have also made very quick work of this. But having that E&M calculator and just plugging the time in there, it will calculate for you those prolonged care codes. So 99215, 99417. The last question I want to look at with you guys is a physician performs a pneumococcal vaccine administration on a Medicare patient. This one may look familiar because I've tested you guys on this one before in some of my CPC prep questions in the past. What code should be assigned for this for the administration? Now remember, we're looking here at this keyword Medicare patient. And we have a bunch of different G codes here. We also have that 90471. Remember, we looked at that and it said that was for a vaccine administration. So we might be tempted to look at that and go, oh yeah, 90471. But if we're smart, if we're for a smart coder, we studied really, really well. We went to a good program like through the AAPC or through Preppy. We know that when we see Medicare patient, we should start thinking about G codes. So if we go into our HCPCS book, We have here G0008 is administration of the influenza vaccine. Which vaccine was this? Pneumococcal. So G0009, administration of pneumococcal vaccine. And remember, those G codes are for our Medicare patients. So that's what we want to be looking at, is these Medicare G codes. So this question is going to be our G0009 for the administration of that pneumococcal vaccine for the Medicare patient. Now, they may also ask you some additional questions in some of these, like the ICD-10 codes, or they might ask you a different variation of this question that has the code for the vaccine itself as well. But I already had this question ready that just tested on the administration of the vaccine. But that's the concept that is most commonly missed on the exam as far as vaccines. The G codes for those Medicare patients, testing you on that, as well as those vaccine components as well. So I hope you found this video helpful. Those are the concepts, the types of coding concepts that are most commonly missed for the CPC exam. So study those sections well, have that information ready. If you need more review, check out my main channel page for that whole CPC review playlist that I have. And keep an eye on contempocoding.com, because I do have some things that will be coming out soon to help you prepare for the CPC exam as well. I will see you guys in the next video. And until then, just keep on coding on.